Good evening and welcome to all of you from your living rooms, I trust, across New Zealand. And my name is Matt Eby. I'm a regional manager of support services down here in the great state of Christchurch in the South Island. And this is a session we've wanted to do for a wee while, and we'll be joined by Dr. James Liang, providing an overview of myeloproliferative neoplasms, a little bit of a focus on pegylated interferon as a therapy option in the management of ET and PV. And yeah, we're just really grateful that you can be a part of the call and speak to us. But a really special mention to Kathy Thomas, and I think she's out there in the audience here, but yeah, without her taking the initiative to actually organize this special talk, this would not be possible. So thank you, Kathy. And yep, I just want to, and I'll be brief here. I just want to do a little bio just to give you a little bit of flavor for Dr. Liang's background. He's a clinical and pathology hematologist with a special interest in adult hematological cancer, while also managing general heme conditions. After completing his medical degrees in 2005 from the University of Auckland, he continued medical training in the Auckland region. In 2015, he was awarded a research fellowship from Cancer and Palliative Network in Perth, Australia. He spent 2016-17 at the University of Western Australia, Sir Charles Gardner Hospital out there. And during his time in research, he mainly focused in the field of myeloproliferative neoplasm with the aim of identifying a potential druggable target. He was also closely involved with developing a novel method of blood-based cancer detection. And then upon returning to New Zealand in 2017, James took up a consultant position at Middlemore Hospital and continued his research interest as an investigator in various clinical trials. So apart from his clinical and research interest, he believes in the importance of disseminating knowledge and having lectured undergraduates, and has been an invited speaker in community events, GP seminars, and international conferences. So with that, an overview of MPNs and a bit of a focus on the pegylated interferon for PV and ET. I'll send it over to you, James.
Yeah, thanks, mate, for that kind introduction. So I'm going to share my screen, see if it works. So here we go. Yeah, thanks for the invitation to do this talk. As Matt mentioned, I had the pleasure of doing my research fellowship, translation fellowship in Perth under Prof. Wendy Erber, who is well, I guess, world-leading researcher, particularly in the area of myeloproliferative neoplasm. So I'm very interested in this topic. Now, I was asked to talk about interferon in terms of treatment for PV and ET, and I'll focus a lot of talk on those. But just before we talk about interferon, it's good just to have some background information, and also the latest, I guess, about what really is going on in myeloproliferative neoplasm. And I guess the more you spend time on it, the more complicated it gets. And also just an introduction about interferon in myeloproliferative neoplasm. There's nothing more you can do to divide the MPN community when you talk about interferon. You're either a believer or you don't. And I guess it is important that when you do talk to a hematologist, there may be different opinion. I guess this is probably where the data is not quite mature. Anyway, here we go. So yes, as mentioned, I'm going to talk briefly about just a clinical presentation, what we call a classical myeloproliferative neoplasm, the science behind it, not too much, but enough just to add a bit of flavor when we talk about interferon in terms of treatment in PV and ET. So when we talk about myeloperipheral neoplasm, it's a great basket of lots of different conditions. And the three things we talk about classical are the polycythemia vera or rubra vera, the PV, the primary myelofibrosis, or the essential thrombocythemia, the ET. So those three conditions are referred to as classical myeloperipheral neoplasm. And you could see the number one, the chronic myeloleukemia, which is also MPN. It's a separate entity with very interesting pathology. Now, I guess that the easiest way for me when I talk to my patient is, what is MPN? The short answer to that is the bone marrow is a factory of your blood cells. You can see from the diagram, the myeloid cells are responsible for the production of your platelet, which help you to clot when you bleed, the red blood cell to carry the oxygen around, and white blood cell to fight different type of infection. So the myeloperipheral neoplasm essentially is where this side of your blood production factory is, I guess, taken over, or in some ways you have some mutation that cause your blood, your bone marrow to produce all these cells, despite your body has slowed down. We don't need so much of them. So that's in essence what happened with the myeloperipheral neoplasm. The problem happened at the top, all these cells here, where they acquire mutation and they keep maturing to become the cells we see in the bloodstream, the white blood cells, big cells, and platelet. Now, there is a possibility, or there's a tendency for some of this condition to progress into two, I guess, more sinister situation. First, when we talk about acute leukemia, this is aggressive blood cancer. Again, what that means in this situation, in this diagram, is somehow these cells here, where they have the mutation in them, stop maturing, stop forming the cells that are useful in the bloodstream, and then just keep growing these cells in the progenitor lineage, and therefore you end up with no maturation of your blood cells, where you, rather than having too much of them, you don't have enough. And that can cause problems where you have no immune system, you have no oxygen delivery capacity, and you have tendency to bleed. On the other hand, you have this condition called myelofibrosis, which the best way to describe it is just scarring of the bone marrow. So that's a quick introduction about what these two conditions are, and I'll talk a bit more a bit later. Now, we talk about polycythemia rubra vera, the PV, and this is again a condition where out of the three lineages, we talk about the platelet to stop you from bleeding, the red blood cell to carry oxygen, the white blood cell for fighting infection. PV predominantly affects the red blood cells, but the more it progresses, the other lineage can be affected. So what we see in the bone marrow, is we see all three cell lines are enhanced or have increased production in the bone marrow. On the other hand, when we talk about essential thrombocythemia or ET, it appears the only lineage, only lines that's affected are the megakaryocyte, the pre-platelet progenitor cells. So you predominantly see elevated platelet count, but in general, your red blood cell and your white blood cell should be normal. Okay. In terms of the other condition, which we're not going to touch on this issue, is the primary myelofibrosis, where the problem occurs where you have increased platelet and the white blood cell production. And what happens is over time, they start to push the red blood cell precursor cells out of the bone marrow, so you become anemic, you don't have enough red blood cells, and then these cells further triggers problem with the bone marrow, and they essentially scarred. You burn out your factory. So that is the condition PVET and PMF. Now, in terms of what does it mean for the patient who have this condition, and it really comes down to the excess production of the red blood cell, the white blood cell, and the platelet. So in a normal situation where you have roughly about 40 to 50% of your blood are cells. The rest are something called plasma, the water, the liquid component, and that's how thick your blood's supposed to be. Now, in a patient who has excess production of, say, red blood cells in PV, you can go up to about 50–60% of all the blood cells and 30 to 40% liquid. If you think about the consistency of that is much thicker, which essentially leads to very sluggish blood flow as your heart tries to pump this milkshake-like material rather than liquid. And your body can struggle quite a bit with that. And as the blood flow slows down, you get all the complications from having blood clots in the circulation where it shouldn't be, because when the blood stops flowing, it clots. And that's where people can have premature, what we call a vascular condition, heart disease and stroke. And a lot of people experience things like this as just itchy skin, as the blood struggle to flow through a tiny blood vessel called capillary, particularly in skin. Now, something completely paradoxical is sometimes when you have way too many platelets, you start to bleed. Now, we talk about platelet is meant to cause your blood to clot. But what happens in some people where there's excessive number of platelets, they start to absorb the clotting factor inside the plasma onto those platelets that are circulating around. Now, if you don't have the clotting factor, you cannot trigger a clotting cascade. Therefore, rather than having blood clots, you start to have problem with bleeding. So this is quite an interesting situation when you have too many platelets, rather than clotting, you start to bleed. Now, there are other situations, it's not a full list of manifestations of MPN, as you have constitutional symptoms, and I'll talk a bit more about that in the basic science section. Essentially, some of these conditions can lead to increased inflammation in the system, where it can cause a lot of symptoms. We experienced fever, night sweat, fatigue. It's almost like your body's constantly fighting infection, a battle. And the last thing you might experience is large spleen, where essentially the bone marrow is full of production. You need more places to make those red blood cells, and start to recruit things like your spleen or your liver, and they start to enlarge as they are taken over by your to make more blood cells. So here is a quick summary about the presentation based on Western society, a lot of other from the States and Europe. And essentially we do at Auckland, I'm from Auckland, so we expect to see maybe about 20 to 30 cases of PV every year, 30 to 40 of essential thrombocythemia, and about 20 cases of myelofibrosis. There's slightly gender imbalance in terms of PV and ET. You see more PV in male and more ET in female. And majority of PV ET present at the age of about 60. But for ET, there is a population, particularly female, under the age of 40, presenting with ET. And in terms of PV, young people do occur at about 10%. Here is just some of those manifestations we talked about. I'm not going to label this slides. This is a lot of clinical slides shared with my colleague. Just a quick summary for them. This is a slide that I created from lots of different articles. And I guess this is an important slide, because this is where the condition of MPD or MPN become more sinister. Now, there is a rate of transformation to the myelofibrosis and acute leukemia we talked about, and this is over about 10 years. So if you have diagnosed with ET, you have over the 10 years time, you have less than 10% chance to transform to the fibrotic, the burnt out phase of the disease, and roughly only 2% chance to transform into leukemia over that 10 years time. On the other hand, if you have polycythemia vera or PV, it's about 1% per year chance of transforming to the burnt out phase, and roughly about 0.5 to 1% per year chance to transform to acute leukemia, where we talk about this as aggressive bone marrow cancer that requires urgent treatment. It is a condition that was coined, I guess, in the last 2-3 years, 2016, 2017, about this prefibrotic myelofibrosis. Now, in this situation, in this condition, there is more tendency to transform to fibrosis, the burnt out phase. The challenge of transforming to leukemia is about the same to ET. Now, this is on the arrow I drew because I'm not quite sure if this is just a part of the continuous process to myelofibrosis or is a separate condition. So it's still debated in the MPN field, anyway, for me anyway. So again, a very busy slide. Now, this is often what people quote from the Interferon in 2014. This is roughly what I call the median survival. 15% of people will be alive if you diagnose ET in 20 years' time, and about 50% will still be alive at 14, and myelofibrosis much more. A complete separate survival curve for them. Now, so this is the caveat is if you don't present with any thrombotic event. So the survival drops significantly if you present to hospital already with a significant blood clot, like a heart attack or a stroke, then that will really affect the overall survival. So a lot of time, this number are used in patient who has no previous thrombotic event. And here is a graph from the same paper showing the black line is the expected survival for the general population. Remember, on average, the age of onset is about 60. So if you can get 20 years for a lot of them, that may be the natural life expectancy. And for the red line is the ET, you could see at least the first 10 years, these lines are just tracking along the same line as the normal population, and start to diverge after that, after the first 10 years, probably reflect the rate of transformation to fibrosis and leukemia. In PV, the green line, you could see even in the first 10 years, there is a reduction in survival compared to the general population. Now, these are some of the tools that we use for predicting your survival. And the one that is bolded, the PVET tool, is created in 2018, is not frequently used because it does include some specific genetic markers that we don't often test. Now, this is a website that you might want to use, and this is based on an article published by the Cambridge group, where they essentially have thousands of people where they can run a very detailed genomic panel to find out all the fancy mutation that can happen with myeloproliferative neoplasm. Clearly, it's not something that a lot of country uses, and it's probably more of a research tool. But I'll see if it works. Now, maybe not. Maybe yes. Okay. So here, this is a link you go in, and this is a website they set up based on the 1,000 patients they have, and all the different risk group they identify. If you put in some key numbers in there, what they say is you could potentially get your individual risk for the condition you have. So it may be something that some people will be interested. So for example, I just make up a patient. So for example, I'm a male, so I'm polycythemic. To use the new patient data, to make I'm 50. My hemoglobin, say, is 190, and my white cell is slightly high at 12, and my platelet number is 550. Now, I'm a male, I don't have previous clot, my spleen is normal, and I have JAK2, and everything else is absent. Okay, and then you could see there's a list of other stuff, other molecular abnormalities. Sometimes we associate with myeloproliferative neoplasm, but I don't know any of these, and that's okay. Let's go to this patient prediction tab, and I can calculate something. So here it just generates a survival curve based on the patient they have, in this case, based on 312 patient, and all the information they have. You could say, well, my 5-year overall survival is 99%. My 10-year is 96. My 20-year survival is 80%. I have about 3.4% chance of transforming to acute leukemia in 20 years' time, while I have about 7% chance of transforming to myelofibrosis in 20 years' time. So there's some predictive marker calculator like this available. Again, not something we use frequently in our clinic. I guess we always think myeloproliferative neoplasm are, well, some people don't believe the cancer, which I disagree. Anyway, so I guess because people do very well, the goal of treatment in PVET cases, and you've probably been told by your clinician, is really to reduce the clot and the bleeding manifestation. And often you involve using aspirin. And for people who have high risk of having stroke or heart disease, where they may be obese, they may have type 2 diabetes or high blood pressure, other risk factor for blood clots, then we sometimes start what called a cytoreductive therapy. And for those people who been around for a while, the go-to drug is hydroxyurea, oral, weak chemotherapy drug to essentially put a lid on the disease. Now, because people do so well, there is a lack of interest from the pharmaceutical group, and in some, and I guess a lot of hematologists as well, that it becomes something you see in the registrar clinic, and some people may not get to see a consultant quite that often with this type of condition. And they're just circulating around, getting venous section, getting medication. There is some, I guess, hope, I guess, in terms of the publication in the last 5-10 years, particularly after around 2010, there are some reports that people on interferon do appear to show that the cancer mutation, the driver mutation, reduces with this treatment, which brought a lot of excitement about potentially if that can be done, can we lead to eradication or cure of this disease? So here it takes me to the basic sciences, and here essentially hopefully we know about these driver mutations. So the JAK2 mutation, the CALR mutation, the MPN mutation. So there's triple mutation. In PV, JAK2 mutation accounts for about 90-95% of all cases. In ET, the JAK2 is about 40-50%, the CALR at 30-40%, and MPL accounts for about 1 to 2% of ET cases. And now here is how the JEC2 mutation works. So here are the cells you have, for example, your stem cell. Here are the receptors for the signal coming into the body. So here is a usual EPO receptor. So this is a red blood cell. This is the platelet receptor, and this is a white blood cell receptor. Now, often what happens if you need signal coming into this receptor to trigger a signal going to the genes and into the DNA to make more copies of it, okay? Now, with a JEC2 mutation, what has happened is this part, the receptor essentially are always on. It never stops. So you don't need signal to cause the downstream effect of what it meant to happen. So this is always switched on. So the way I talk to my patient is with the mutation, your body is always on. No matter if you have signal or not, they'll keep making the product. And the same thing happens in the CALR and MPL, except it only affects the platelet receptor, and that causes the production of excessive platelet or red blood cell in this situation. Again, same thing, showing you the driver mutation, the 3 mutation we talked about. In ET, JEC2 account for about 40%, CALR the next 30 to 40, MPL a small amount, and about 20% of people are what we term triple negative or TN. So for some reason, we just cannot find a mutation that causes what we see, the increase in platelet count. Of those people who has this triple negative ET, those people do really well. And we do wonder if this is a real, or I do wonder if this is a real population or not, or the increase in platelet count is due to other underlying medical condition like an inflammatory condition rather a true bone marrow disorder. On the other hand, we talk about PV, where essentially JEC mutation accounts for most of the cases. There's about 5 to 10% of cases where we cannot identify a JEC2 driver. And the more we know about PV and the better we are in terms of looking at our genomes, we start to find different JEC2 mutations along the way. And a lot of those hidden 5% have mutation outside what we call the hotspot, and we can only identify them by sequencing of the JEC2 genes, which we don't do often. Just the difficulty of doing that and apply that in a clinical setting. Now, outside the triple mutation, there are lots of other mutations that also can occur with these type of condition. Now, the reason why I want to bring that up is it's probably referring to, I'll probably just skip the slide. Now, it's referring to what I call the passenger mutation. So, I don't know, during the lockdown, I watched a bit more TV than I normally do, and there's an ad from the police about speeding, isn't it? So you get on the ad, you got the passenger sitting there, and there was some voiceover say the driver makes a decision, and they drive as fast as they want. The other driver, they make the decision. So I guess that's what we think about initially about MPNs. You have the JEC mutation, you have a count mutation, or you have a MPL mutation. Once you have that, it drives the disease forward. I think what we know in the last few years is it may not be as easy as that. Certainly the JEC, CALR, MPL is very important. The passenger mutation, it looks like they're starting to become more and more important. There are research like this which shows, yes, you need those driver mutation, but there are studies where people have a JEC2 mutation in their system. I was completely healthy for 10 years before they manifest the what we call the phenotype when they have the increasing red cells and platelet. So they may be associated with what called initiation. Maybe another mutation to happen on top of those driver mutation to manifest that disease. Now, after that, we worry about the transformation to fibrosis and acute leukemia, and they may require mutation, again, further mutation along the way that leads to further progression to become the fibrotic disease or the acute leukemia disease. So I guess if you want to think about it, maybe it's more of the teenage driver where if you sit next to your mom, you'll probably drive a lot more safer than sitting with your mates. And I guess that's a reason for the restricted license, isn't it? So now, again, this may be a bit too geeky, but I think while doing 6th, 7th form year 12, year 13 biology, we learn about genetics. So essentially, the gene you have, the Mendelian model. If you have black hair, you should have, if the gene codes for black hair, you should have black hair. And I guess that's what I thought about this condition for a long time. If you have a gene, you code for black hair, you should have black hair. But the more we learn about genes is actually, yes, you might have a DNA, you might have a gene that codes for black hair. And yes, if it expressed, you will have black hair. But in order for that gene to be expressed, to turn it into the action, to turn it into the protein, you need things called epigenetic. You need things to unwind the DNA so that DNA can be used to make the protein. Now, this is where people start to talk about epigenetics, where the unwinding bit can be potentially controlled by the environment. And therefore, this is where there's all this environmental factor leads to different outcome and different expression of your genes comes in. So this is how environment affects your genetic expression. And the reason I mention that is a lot of the disease, a lot of mutation that we associate with MPN that potentially initiate, potentially progresses the disease further, is all to do with epigenetics. This is just another example, another medical term called CHIP. Essentially, it's an idea where as you age, so this is time, as you age, you do acquire mutation from time to time. A lot of them are what I call a bystander mutation. It just occurs there. It doesn't do anything. Until in this situation where you have a mutation that does have some growth advantage. So now you have this mutation, the red mutation, where this cluster of cells start to become more and more prominent over time. And this is what we term CHIP. This is a clonal blood cell disorder, but we don't know what it means. It's indeterminate potential. Now, some of them could stay like this and have no problem. But then if they acquire another mutation where I guess you think about it could be the initiation mutation, then this becomes the myeloproliferative neoplasm we see. And then finally another mutation that transforms into more aggressive form of the disease, and that's acute leukemia. So this is, I guess, what we think is going on, or the more you study this is not as easy as simply those 3 mutations we worry about. There are probably a lot of other mutations that plays a very important role. So here is what I drew end of last year or beginning of this year after I went to the American Society of Hematology meeting, where I spent about 10, 15 hours listening to talks, and all it is trying from all the basic science that comes out is, yes, maybe the driver mutation is very important, but there are a lot of other epigenetic factors that switch on, switch off the gene that's also very important in proliferating the disease. And a lot of them is to do with the fibrosis part, is to do with the inflammation signal that drives the fibrosis, and it's a positive feedback where more inflammation drives more fibrosis, and then also inflammation leads to further growth of the myeloproliferative, the cancer clones, and that leads to more symptoms and potentially leads to further mutation down the line before we hit the leukemic transformation. So I think that's where we are. And certainly a lot of the times where the treatment are not just focused on treating the JAK2 clone, a lot of novel therapy in MPN involves modifying these epigenetics, and I'm hopeful that it will start to come through in the next few years. So now back to the main topic, interferon. Okay. I don't have a lot of time. So how does it work? Well, we don't know. The short answer is we have theories, but I don't think we really know how interferon works. So interferon are a biological hormone made by your white blood cells and is there to fight infection, but at a super high dose we use, it is shown to cause to inhibit the self-renewal of your stem cell, your MPN stem cell. It causes them to mature, so you don't have accumulation of those nasty stem cells, and then it somehow blocks them so you don't produce too many of the daughter cells, which means your blood count will hopefully falls into normal. It's an unknown mechanism that stops the transformation. So overall, we don't know a lot, but it certainly does work, and it's based on probably chronic mild leukemia treatment many years ago. This is one of the common therapy prior to the Glyvac days. So there are two types of interferon. Interferon has been given subcutaneous injection. Unfortunately, there's no oral form for this. There's a short-acting, which is funded by Pharmac. The starting dose is 3 million international units 3 times a week, so that's a starting dose. While the long-acting unfunded given roughly about once a week. The starting dose is listed down here. Interestingly, it comes at 180 microgram syringe. So if you do follow this, a lot of drug are wasted. Now, there are two types of long-acting interferon. In New Zealand, we have the PEG interferon alpha 2A or Pegasus. We don't have the 2B type. When you look at the literature between 2A and 2B, not in myeloproliferative neoplasm, because there is no direct comparison, but in treatment of hepatitis C, which these two drugs are primarily used, they appear to have similar efficacy in hepatitis C treatment. So we don't think there's any major difference between the way the 2A and 2B. It's a different way to turn it into a long-acting drug. Now, there's no direct comparison of interferon in terms of short-acting versus long-acting in myeloproliferative neoplasm. So we do think PEG interferon probably are more better tolerated, but there's no head-to-head comparison data to back that up. In terms of why we were hopeful that this could be a game changer, because there is just some weak scientific evidence showing it does work. So roughly about 80% of people who are on interferon are able to control the myeloproliferative neoplasm. And for those who, for some reason, either intolerant or fail hydroxyurea as a first-line therapy, you can salvage them with interferon. So 60% of PV can be salvaged with interferon, and 70 in ET if they fail hydroxyurea. And there's just some weak evidence suggests it may be better. So this is where I'll go to a few studies that were just recently either presented as oral abstract or published, comparing this head-to-head in the first-line setting. Now, there is again, based on those weak evidence, there is some concerns about toxicity, and it's frequently reported about a third or 20 to 30% of people will stop the interferon treatment due to toxicity. A lot is to do with the flu-like symptom. Remember, this is a biological product made by your white blood cells. And so if you know what your white blood cells do is they fight infection, and when they do, you feel like you have a flu. And not surprisingly, people, if you inject ultra high doses, do feel like they have a flu. And that's why their symptom sore muscles and joints and headache. And there are more even incidents of depression in this group, and also some evidence that it causes autoimmune manifestation. Again, there was some talk about the interferon somehow modifying the immune system so it picks up cancer cell more readily. But at the same time, your immune system are a bit overactive, it might start to damage your own body. Now, again, as I mentioned before, there are all these publications showing actually the JET2 mutation burden do improve with this treatment. So could this be the cure we're looking for? So I guess a couple of years ago, 2018, this is presented in American Society of Hematology, one of the major meeting in hematology at November, December 2018. In that presentation, in the oral abstract setting, there was 3 head-to-head comparison in a randomized control fashion between PEG interferon and hydroxyurea. The first presentation was this MPDRC group 112, where they have about 80, 90 patients each arm, and it's used to compare people with ET and PV. And there was a huge disappointment. This is the first presentation at session, where they noticed there's no difference in outcome at 12 and 24 months after treatment. And there's a similar rate of toxicity between the two groups. So that was very disappointing. But then there's a couple more presentations. One is from this PV and continuation PV data, where again, this is only in polycythemia vera. Again, roughly about 80 patients each arm, interferon versus hydroxyurea. And the interferon they use in this PV, in this PV study is interferon 2B, which is the one we don't have in New Zealand. And there's a DELIA study with a Danish group. There's only about 30 people in each arm, not particularly big study, but they have a similar outcome in PV patient where there is evidence if you keep going with treatment a little bit longer, for example, at 36 months, they do appear to, the interferon do appear to do better, and they do appear to have deeper, I guess what I call a molecular response, where the JET2 burden is lower. In the PV, the dropout rate is less than 10%, but in the DALIA study, about 30 to 40%. So there's a huge variation in the dropout rate. So before I talk a bit more about the PV study, where there's a recent update last year, I just want to show you the side effects. Now, they do mention the side effects are very similar in terms of the rate between the two groups. I'm not sure this you're going to see it that clearly, but there is a difference in what side effect people experience. In hydroxyurea, a lot of people do experience fatigue. Grade 1, 2 are very mild. Grade 3, 4 are a lot more significant. So a lot of people have mild fatigue in hydroxyurea compared with people on pegylated interferon, where you don't have as much fatigue in this group. But then you look at headaches, you have a lot more headaches and more severe headache in the PEG interferon. You have a lot more flu-like symptoms, essentially 2.5% versus about 22%. And then more abdominal pain in the PEG interferon. This number seems high. About 10% of people will have depression compared to about 2.5%. The rate of depression listed in the drug brochures is about 0.1 to 1%. So that's quite interesting. And then there is a bit more high blood pressure in the PEG. So overall, the amount of side effects are similar, but it's just different side effect compared to your hydroxyurea. So this is the most recent update of the PROUD PV study and continuation PV study that was presented last year and was published in manuscript in Lancet a couple months ago. And this probably a good illustration of what we think might explain the difference in those two randomized control trial, or the three randomized control trial, where you do seem to have better outcome with longer duration of treatment. Now, this is the presentation here, since I'm going to use a lot of the slides, so I need to attribute to them. So this is the slide that was presented. And look, this is what return complete hematological response, i.e. your blood count normalizes. So a picture, this hopefully make it easy. So this is at the start, this is time under here. So every little bit is about 3 months. Here is the number of responders on your y-axis. I think that's y-axis. And here we could see at the start, and over time, the red line is your peak interferon arm. The greenish line, I think, greenish brownish line is your hydroxyurea arm. So if you actually look at this, you could see if you are treated with hydroxyurea, you actually have better response to treatment initially in terms of your blood count normalizing. And there's a bit of lag with interferon. Now, it does cross over at about between 18 to 21 months time in this study. And after that 21, 24 months, you could see your response to peak interferon is superior to your hydroxyurea. And I guess this is where it's quite interesting to see this, where maybe that's why the study from MPDRC group, where the results are published at 12 and 24 months, didn't show any benefit, is because we haven't quite seen this crossover yet. Now, so if you look at a bit more deeper, what does that mean in terms of venous section? So again, not surprisingly, this is the hydroxyurea or control arm, this is interferon arm. You could see for the first 2 years, you could say hydroxyurea treated patient has this venous section, but again, it flips after that 2-year mark. Now, this is probably what we are all waiting for, is this is a molecular response data. And the way, I guess, it tracks exactly what we see in the hematological response data is, yes, with hydroxyurea, it does reduces the molecular burden of the MPD or MPN, but just like its hematological response, the effect seems to wear off over time. While the hydroxyurea, while the peak interferon arm, the effect seems to slowly build up and maintains after that 18, 21 months time, and then it flattens out. So this is a very interesting data to see, where in some way you could say the hydroxyurea do reduce disease burden, but the effect is not sustained, while the interferon arm, the effect seems to build up and seems to be able to be sustained once you have you achieve that remission at 2 years time. Here is a bit more about the JAK2 burden. You can see this is the interferon arm, this is the hydroxyurea arm. You start at about 37% of JAK2 burden, or cancer burden, if you want to put it like that. And you can see tracking exactly the same, seem to reduce over time and seem to pretty much stabilize. Hydroxyurea, good reduction, even better reduction than peak interferon initially, but then the effect seems to lose over the next few years. Now, what I do find this curve interesting, and this is our presentation, and it will require a lot more teasing out, is certainly those who respond do seem to respond and do seem to continue to respond. But if you know the box and whisker graph, this top line is the top 25% quartile. That seems to be creeping up. To me, that suggests a group of people do very well with this treatment, but maybe a group of people will start to relapse, just like your hydroxyurea arm. And again, those are things that hopefully with more time, we can figure out what may be going on. Here at 4-year mark with this interferon treatment, just want to show you people with interferon arm do achieve deeper remission. People with hydroxyurea arm do achieve some molecular, some of them do achieve quite a good molecular response between 1 to 10%, but clearly not as many as the interferon arm. Again, in this group, is showing they have similar side effect between the two. And for those who are interested about interferon exposure over a long period of time, here's what they show. In the first year, everybody with this roll-pack interferon, they're on essentially full dose of fortnightly dosing. And with time, you can see, particularly maybe after they switch over that 2-year mark, a lot of people reduces their interferon usage to every 3 weeks, every 4 weeks, about 50-50. And overall exposure to the dose reduces. Again, the first couple of years, you seem to be a bit higher dose, but particularly for those who do respond, you can reduce your dosage of interferon over the course of the 3rd, 4th year, and probably ongoing. Well, we don't have data to support that, but it does appear to be what it looks like. So I guess this is a summary slide I have for interferon in PV. Now, I right down the bottom, I just don't have enough evidence to talk about ET, and there still don't appear to be a lot of evidence coming through. But certainly in PV, interferon do appear to be a better treatment than hydroxyurea in terms of long-term disease control. And we saw that with less venesection, better blood count control, deeper remission, and switch occurs about 2 years into treatment. And for those who respond, for those about 60% of people who seem to respond very well, then there is a role of dose reduction. The side effects are similar in terms of the rates are similar, but it's a different type of side effect we see between the two groups. In some ways, what we still don't quite know is why some people achieve the response while other people don't. We just don't know that. And when the people who did the continuation PV talked about it, again, they went through all the driver and passenger mutation, and they just and the doses they're getting, they just didn't get any sense why some people do better than others. What we don't know if the deeper molecular response lead to improving survival in terms of less fibrosis, this acute transformation. And probably a lot that to do is because we just don't have enough information. In order for us to see this, because it's only occurring at 1% per year, we need a really long tail in terms of follow-up. And again, and what we don't know is if the deeper response do mean that we can stop treatment somewhere along the line, and where that could be is hard to know. So there's certainly a lot more we need to know about interferon, but clearly it does appear to be a great long-term treatment. But people need to be aware and need to be motivated, because you actually get a better treatment with hydroxyurea in the first couple of years than interferon. But if you can stay the course, you do end up with better potentially disease control. So that leads me to the question session. And these are some of the questions I've been asked. Do you want me to go through them?
Yeah, James, feel free. Yeah, great presentation. And this is a great time to go through the questions, and then we'll see how we go. There's a few other ones that have popped up on the Q&A box. Yep.
Yeah, so I guess Is peg interferon your preferred treatment for, I think it's PV? I think for me, it does depend. I certainly that PV data is very interesting. I think it's really if this can be sustained, and certainly for younger people, it may be something to think about. So there's some suggestion maybe people under the age of 40, you might want to try peg interferon as a first-line therapy. In New Zealand, obviously, we don't have funded access to the peg interferon, so often we'll potentially use the short-acting one, which we don't have any data on efficacy because there's just no trial about the short-acting interferon and the response to PVET. And I've talked about the dosage, the question 2, at one of the slides. And the optimal dose essentially is what you can tolerate and what controls the blood count. So we often start at a low dose and go up because that's probably the best way to minimize toxicity. And some people do say your body, with time, you can get used to some of the toxicity and you have ways to mitigate some of the toxicity. And so that's how the dosage design is start lowish and up titrate until your blood count is under control. We briefly covered dose reduction and maintenance dose. Again, that tends to occur after 2 years for those responding to therapy, and you could reduce the dose and the maintenance dose depending on what you can get away with in terms of hematological control. Stock in COVID-19. Well, I don't know about this. I don't have a feel about stock. I don't hear any problem with the stock due to COVID-19. I do hear about potentially the drug company who makes interferon alpha 2A not willing to make any more of this drug because, as I mentioned, this is primarily used to treat hepatitis C, and hepatitis C has now much better antiviral therapy. So the market for interferon is much smaller, but that the ins and outs, I'm not sure about that. So there is a question mark about future access to pegylated interferon. Cover some of the side effects, and again, pharmac-funded application. Certainly, a group of us are very interested to get the peg interferon funded. We're certainly working on some doctor-led application before the COVID-19 lockdown, particularly with the publication of the parallel conjugation PV data beginning of March. So we get something physical to show pharmac. I don't think there's a lot of resistance, but I think it will require, once COVID-19 finish, hopefully we can get over the line. If you look at the cost of interferon 3 times a week and the cost of pegylated interferon once a week, the cost come out to be the same. So from the pharmac budget wise, I can't quite see the difference. But that's what I think, which is not very important. Is hair loss thing reversible? Again, good question. It's definitely reversible based on what we read and based on what we know from the hepatitis C and from the MPN data. It may take about 3 months after stopping treatment to notice the improvement, and we're not quite sure about dose reduction potentially can mitigate some of the hair loss. But that's as much as I know. Now, I think there's other questions.
Are you able to see those, James? Those,
Yep.
Yep.
Yep. So why is PEG interferon not funded? Good question. I guess if you base on literature, the only convincing data for potentially finding PEG interferon just came out 2 months ago with a PV continuation PV study. So I guess if we truly talk about what I guess from purely medical data point of view, I suspect that's probably one of the main reasons. A lot of are in abstract form, which lacks the scientific rigor sometimes needed to make these submissions. There's some talk about analytic burden. Now, there's a very good question about in New Zealand if we can test JEP2 analytic burden or not. I do know some places that can be done. I think Christchurch can do them. I know certainly if you need to, I think Auckland can do them. It's not if you can or if you can't. A lot of labs, the way they set out their molecular study, a lot of them can probably do the analytic burden. What we do not know, and this is where the clinician put their head on, is we at this stage, the analytic burden doesn't guide us in terms of treatment. And this is where things are a bit more complicated, where yes, it may be good to see your alert burden coming down. But if it doesn't, and if you are still in a hematological response, we don't know what to do with that. It's because we don't know if the lower alert burden leads to less disease. As we can say, yes, the number looks better, but does it reduce the rate of transformation to fibrosis? Does it lead to reduced rate of transformation to acute leukemia? The short answer is we don't have any of those data, and those data is not going to come out anytime soon. The next question is a really interesting question, where can we combine treatment? And I think what hopefully I somewhat alluded to with my presentation is, I think the way to go is not one or the other. I think the way to go is, like you said, a combined therapy, where we not just want to target the cancer clone, the JEP mutation. We want to probably target the passenger mutation, the epigenetic and factor that we see in this disease. So certainly those are things where the more you look into this topic, the more you want to do. That said, I don't know if I mentioned that the MPD-RC, where we got 80 people in each arm, that study took about 5-6 years to recruit 160 patients. And they were aiming for 600. So it's really hard to recruit in this patient population. And we're only going to see useful evidence if we get a lot of people on these trials. So yes, I think definitely combined treatment is better than single treatment. I certainly believe in that, but it's hard to know what to combine with, and if we get enough people data to prove that. The next question about the short-term interferon, the answer to that is we don't know, because there is no comparison between the efficacy of short-term versus long-term interferon. And most of the data is coming out from pegylated interferon, long-acting interferon. But again, the only difference between a short-term interferon and pegylated interferon is an extra few molecules that add in front to reduce the clearance so the active component appear to be the same. So my short answer to that is I can back that up, but I think they should be the same. what is the cost of using pegylated interferon? Now, this is what I just Googled about 30 minutes ago, or actually 1 hour ago. The cost for the pharmac is about $500 for full syringe at 180 microgram. So if you use 45 microgram a week, if you don't recycle, i.e. if you only use 45 out of 180 and throw away the rest 135, it roughly costs about 5,000, 6,000 a year. It's a lot of money in terms of if you have to pay, but it's not a lot of money in terms of pharmac budget. If you talk about interferon, it costs about, for pharmac, each just short-acting interferon costs about $38. So it actually works out pretty close if you use 3 times a week to the weekly dose at 45 microgram. So I guess that's a financial things we can talk about. There is a question about interferon and intermediate to MF. Again, good question. This is probably a bit outside the topic. I think, yes, there are evidence it does work for intermediate to myelofibrosis. And yes, it's in the same patient population as those who will qualify for ruxolitinib. And again, I don't want to be controversial. To me, the money is in combined use. And there are some study, hopefully we will see a lot more of it, where we start to combine the interferon and some more targeted therapy like a ruxolitinib for the JAK2, where it do appear to be synergistic. Now, for those who want to use interferon for intermediate to myelofibrosis, clearly what we need to know before that is this patient transplantable? So for those with intermediate to MF who are potentially transplantable, we really should be transplanting them for a cure. Ruxolitinib and interferon will not give you that cure. Now, if the patient are transplantable, then there is concern of using interferon prior to transplant. There's some data showing, possibly because of the immune modifying effect of interferon, people do horrendously who after transplant who has been previously treated with interferon. So I think that's another patient population where if you intermediate to MF, not definitely a transplantable candidate, but maybe not quite ready. In that patient population, I will not use interferon. Hopefully that give you a bit of idea. Not a straightforward answer. So when diagnosed as a young teen, what are the chances of needing a bone marrow transplant later in life? So the short answer is very likely. If you look at the data, the chance of progression is about 1% per year. If you diagnose with in a young teen, there's a good chance you either develop myelofibrosis or you transform to acute leukemia, where bone marrow transplant is the only cure for this condition. This is based on simple statistics. We don't have any long-term data, but that's what it looks like. What will be the alternative treatment be if they remove interferon from the market? Well, another very good question. I guess it will go back to the dark days of hydroxyurea. If that doesn't work, will be a short-acting interferon if that's still available. If not, then we do know ruxolitinib do work for PV who has failed hydroxyurea. I'm not sure if that will be something the pharma will be looking at funding. And I guess ultimately is trying to find other drugs piggyback off any myelofibrosis trial, which check to myelofibrosis, any other treatment that we can get from the other MPDs. So there's not a lot. You can use busulfan, another stronger chemotherapy agent, but I will not use it for young people since that can lead to increased risk of leukemic transformation. So yeah, so there is not a lot of, I guess, what I call FDA approved treatment in PV and ET at this stage anyway, simply because there's not a lot of interest up until more recently. There's just not enough money to be made by the pharmaceutical company in this area because of survival. Will pegylated interferon be funded for ET? Tough. Like I said, there is no randomized control. There's no strong evidence that pegylated interferon works better than hydroxyurea in ET. A lot of data are from PV patient. And the only people that study ET was the MPDRC 112 trial, which is now already closed, and we won't get to see any long-term data at 3-year, 4-year mark. So that remains an unanswered question. I don't know about what happens if the short-acting interferon is discontinued by the drug company. Again, are there any other drug company willing to come to the market in New Zealand? So again, that's not something I can answer, unfortunately. Tony asks, how do we in New Zealand get into these overseas trials? To get around funding? The short answer to that is it depends on, I guess, relationship. I mean that by New Zealand is not a country that it's particularly in the MPN field, is not a country that a lot of research company with their new drugs want to come. I don't think we have enough patient population for them to set up a specific research in New Zealand. But we do have relationship with Australia, which I guess is big brother, or some people mention part of New Zealand now, with our Prime Minister doing so well, that we do piggyback some of the study with them. And I guess also we just need to make ourselves known in New Zealand that we are a place that are interested into MPD research, MPN research. And I guess the example I had was I think we have some direct communication with one of the MPN research, Claire Harrison in UK, and out of the blue there was an email from her about a new drug company looking for ET patient to do some MPD research with their new molecule they have, epigenetic modifier, and that was a story of how, I guess, in Middlemore and North Shore, we are looking at starting a treatment with this new drug that in ET patient that potentially may look interesting. It certainly has some preliminary data in myelofibrosis and is encouraging. So I guess the short answer to that is just getting yourself around, talking to different people. So I spoke to them during ASH last year, and that's how we got them to come to New Zealand. So I guess you just need a bit more people who are interested and be proactive, hunting for relationship and letting people know New Zealand is a great place to do research, particularly in the MPN field. We have no dedicated research for a long time. So most our PV patients, most our ET patients have not had any research, been exposed to any clinical research. and this is an untapped field for a lot of research companies that really want to come with their new molecules, and that makes scientific sense. So I guess that's my answer to that. And finally, do you follow study from overseas? Short answer is yes. We all the research essentially are from overseas, and I guess the way, depending on the research here, that they should be able to be translated, particularly those with randomized controlled trial. So hopefully, if the research done well and published in a journal rather than just an oral extract, hopefully all this will be screened and will be verified and should apply to New Zealand. I know we do have Maori Pacific Island population, and those there may be some genetic polymorphism in those groups that we don't know about. They may study a different disease outcome, but in general, research hopefully should be able to be extrapolated and applied to New Zealand. Cool. Hopefully that's it.
So, hey, James, there was one other question just off the call.
Yeah.
I'll just try to ask. When you were going through the slides with like the pathogenesis, and there was like that slide that talked about like the inflammation signals and pathways that could lead to fibrosis and stuff. Is there anything a patient can do to kind of control this, like inflammation, like through diet or anything like that?
The short answer to that is probably no. Certainly you can, you know, there's a lot of talk about how to control inflammation. Now, a lot from what we do know is from the animal model, and a lot of those basic science are for animal model, and we don't really know if that applies to human. There are signals that is secreted by your malignant cells. So you can reduce the underlying inflammation, maybe a gluten-free diet, things like that. But that may not be enough, because your cancer cell, your malignant clone, is it's themselves secrete this inflammation molecule. And there are evidence the cancer cell itself has this receptor that are oversensitive, overactive in terms of identifying inflammation around the body. So even a small amount leads to significant stimulation of the cancer cell for growth and production. So I guess you can try to, by minimizing exposure to weird and wonderful antigen, but I think that it's probably not something you can do, really.
Okay, and I appreciate that. I think you've smashed through all the questions in record pace. So that was so well done. I think that's probably the wrap up of the talk. I think that's everyone. And yeah, just very comprehensive. We really appreciate it. I'm speaking on behalf, of course, of everyone in their living rooms across New Zealand, clapping to you. And LBC is very, very grateful that you could give of your time tonight. So yeah, so with that, that may be the end of our MPN session. But again, thank you so much, James, for talking to us tonight.
No, it's my pleasure.
Yeah. All right, guys, go well. The rest of you, take care. See ya.